Hi, and welcome to episode number 16. I'm Joanne McIntyre, your host, and today it is my pleasure to be speaking with Dr. Porges again. We spoke back in episode number 5, where we focused on the background information in developing the Safe and Sound protocol. In today's episode, we discuss cardiac vagal tone and heart rate variability. Dr. Porges will discuss what heart rate variability is and why it is important. But to get everyone started with a basic understanding, heart rate variability is the measurement of the time interval between each heartbeat and is considered gold standard in measuring stress in the nervous system. But before we get started, I'd like to formally introduce Dr. Porges. He's a distinguished university scientist at Indiana University, where he is the founding director of the Traumatic Stress Research Consortium. He is professor of psychiatry at the University of North Carolina and professor emeritus at both the University of Illinois in Chicago and the University of Maryland. He serves as president of the Society for the Psychophysiological Research and the Federation of Associations in Behavioral and Brain Sciences, and is a former recipient of a National Institute of Mental Health Research Scientist Development Award. He has published more than 300 peer-reviewed scientific papers across several disciplines that have been cited in more than 30,000 peer-reviewed papers. He holds several patents involved in monitoring and regulating autonomic state. He is the originator of the Polyvagal theory, a theory that emphasizes the importance of physiological state in the expression of behavioral, mental, and health problems related to traumatic experiences. He is the author of the Polyvagal theory, Neurophysiological Foundations of Emotions, Attachment, Communication, and Self-Regulation, the Pocket Guide to the Polyvagal Theory, The Transformative Power of Feeling Safe, and the co-editor of Clinical Applications of the Polyvagal Theory, The Emergence of the Polyvagal Informed Therapies. All these books are available through Norton. Dr. Porges is the creator of the Safe and Sound Protocol, which is what our podcast is about, the acoustic intervention, which is currently used by more than 2,000 practitioners around the world to improve spontaneous social engagement, reduce hearing sensitivities, and to improve language processing, state regulation, and spontaneous social engagement. So welcome, Dr. Porges. Again, thank you for coming and being so gracious with your time to share your knowledge on the Safe and Sound Protocol podcast. And as I mentioned in the introduction, we're going to be talking about heart rate variability today. And so I thought maybe we'd start with if you can talk about some of your early research and how you stumbled, or not actually stumbled, how you developed that. Stumbled, okay.
You can use that.
Into developing this awareness, this knowledge base.
Yeah, well, it's an interesting story, but it all comes down to how good an observer are you, and what questions do you ask when you observe different patterns, physiological patterns. For me, heart rate variability goes back to the middle 1960s when I was in graduate school. Now let's move to 1967, actually, when I was working on my master's thesis, and we were putting electrodes on, measuring heart rate, measuring electrical activity or sweat gland activity off the hands. It was a new discipline. The discipline was called psychophysiology. It was very new. And it was kind of exciting because the idea was you can see the person responding without asking them a question, just looking at their body. So it was this curiosity of what's below the surface of behavior and actually speech. And I just found it just a remarkable and interesting area. So I started to do my master's thesis, and it was very basic research looking at heart rate reactions and breathing reactions and electrodermal reactions during reaction time and various forms of sustained attention tasks, including interoceptor one, attending to one's own heart rate. And we started to notice certain things. We noticed that when people were in a state of sustained attention, heart rate started to stabilize, being the beat-to-beat variability kind of flattened out. And we stopped the research because we weren't measuring respiration, and we wondered whether or not the effects we were seeing were merely a function of the person not breathing or inhibiting breathing. So like I'm leaning forward or I breathe more shallowly, it helps me attend, but is the impact on the beat to beat heart rate, the reduction of that variability, basically an epiphenomenon because of my breathing? So we ran the study, we got stopped it, got the device to measure breathing and started the study all over again. And now we were looking at these beat to beat changes. And we found out that the beat to beat changes in the heart rate variability during sustained attention uh, wasn't being driven solely by breathing. Breathing was, in a sense, non-discriminatory. It was more of a generalized response. But if you gave people different attention loads or mental effort loads, the heart rate variability seemed to separate that out nicely. And so this was published in 1969 in the Journal of Experimental Psychology. And it was probably the first paper that quantified heart rate variability. But it did something else within, I would say, I also started asking the question at that point in time, what were the individual differences? If people had more heart rate variability, were they the ones who, by nature of their own physiology, were better attenders, faster responders, and made more reliable heart rate responses? Now, I've got to give you a little history here, because the history at that point in time was heart rate variability didn't exist. It was a product of not controlling your subjects. People were, in a sense, very behaviorally oriented in their thinking and not very neurally oriented. So I remember getting criticized when I was describing heart rate variability, and one established scientist, dominant, in fact, in the area, says, "Steve, the reason you have heart rate variability is you're just not a good scientist." And it was this belief that the heart was just there doing nothing except responding to stimuli. It was a very naive viewpoint. And the dominant measures of heart rate were, did the heart rate go up or did it go down? It was directionality. And in anticipation of stimulation, heart rate often dropped. You actually had conditioned reactions that were temporally mediated. So the bottom line here was that people were not, they were measuring physiology, but they had no interest or any knowledge regarding the neural mechanisms that were creating these physiological changes. And that was kind of the space I fell into. And that became my journey, was not merely to describe this phenomenon, but to try to understand the underlying neural mechanism. And then for my dissertation, which was completed also decades ago in 1970, and that paper was published in 1972, established that the individual differences in heart rate variability were related to whether or not people had faster reaction times, better attenders. And that was probably the first introduction into the literature that heart rate variability was a positive attribute. And actually research moved on from there. But following 1972, my research started to go into asking the questions, what was the underlying mechanism? And that's where this whole interest in vagal phenomena occurred. And if you track the literature, no one mentioned the vagus in psychophysiology. The dominant view was sympathetic nervous system. People talked about arousal. They didn't talk about homeostatic function and vagal regulation. It just wasn't in the literature. So that's where it started. And the mechanisms then, the question was, variability is just a simple statistical description of the beat-to-beat variance. It doesn't tell you anything about patterning. But when you look at the data, you start seeing that there are these rhythmic oscillations in heart rate, which are called respiratory sinus arrhythmia. And that was really, my journey was to kind of map into that literature, understand what that was doing, do studies with animals, do studies with preterm babies, look at the developmental attributes of it, look at the effects of blockade and electrical stimulation on it, to create a validation that it was possible now through a simply, easily measured peripheral autonomic measure to get an insight into the brain's regulation of our homeostatic function. So I never viewed heart rate variability, or what I was calling cardiac vagal tone then, I never viewed it as simply, quote, an autonomic measure. I viewed it as a neural measure of how the brain was controlling our viscera. I was viewing it as a window to the brain.
Mm-hmm, mm-hmm. And I think when I was preparing for this, I was reading one of your earlier papers, the cardiac vagal tone, the physiological index of stress. And I think, in the general sort of knowledge base, when people are learning about HRV, people kind of think that they're measuring a stress response. So I'm looking at a stress response. But in this paper, you very sort of clearly sort of provide the framework to sort of show that, to discuss homeostasis.
Yeah,
And I'm going to let you unpack this, but
yeah.
it definitely brings you awareness where what we're measuring is homeostasis in the nervous system.
Right. And if you move forward 50 years or so, I'm still at that same point. I think we've misunderstood uh, the nervous system of the human and mammalian autonomic nervous system, and we use terms like stress, which are, in a sense, distal constructs, and then we look for measures without understanding the physiological consequence. So this frequently use of cortisol as a measure of stress is really, I would say, outrageous, from a neurophysiological level and from, in a sense, a health or medical level. Cortisol has certain functions, adaptive functions, and if we understood those better, we wouldn't call it stress. We would call it a neurochemical support, an endocrine support for mobilization. And if we accept it as an index of stress, then all movement is stress. And that led the stress physiologists and psychophysiologists into a quandary. And then they had to talk about good stress and bad stress. Now, what I now say is, isn't it much easier to think about disruption of homeostatic function? And when you look at even the physiology of what that vagal index is, it's the oscillations of heart rate through the vagus, which are functionally being turned on and off with our respiratory cycle. And that's within the brainstem. The respiration is, in a sense, a gating mechanism that is in the brainstem area. And what we can see is that when people have lower amplitude respiratory sinus rhythmia or less cardiac vagal tone, they have all kinds of other comorbidities. Their autonomic nervous system is dysregulated. And what I've developed now, we're testing it in several studies, is a new metric, which I call vagal efficiency. And so it's not merely that you have higher amplitude oscillations, it's whether changes in those amplitude of those oscillations are effectively changing heart rate. So if you have a vagally efficient system, if I want to get up, I change that vagal brake, I change the amplitude of those oscillations, and now my heart rate beats faster, and I have more energy, I move, I don't need my sympathetics to come on board, and when I sit down, it comes right back on board, and I have resilience, and I'm self-regulated. Now, what we're showing, this is a really nifty research, because people with trauma histories, that vagal efficiency is less. It's as if their feedback loops of homeostasis have already been challenged. And this is occurring long before there's end organ damage. So you're seeing, in a sense, disruption of homeostasis before you're seeing, in a sense, the end organs. And this is another important question that the medical profession, internists, look at end organs. They don't talk about the neuroregulation of those end organs. Even when you get a stress test, they're looking to see if they can disrupt the electrical conductivity on the myocardium. They're not looking at vagal regulation and whether it comes back quickly or how it comes back. Likewise, they're not looking at any other organs as having a neural surveillance system that's regulating the brainstem. And that's functionally what our vagus is. It's primarily a surveillance system that is measuring the status of those organs and then sending cues back of what to do. So back to your point, I think it's so parsimonious to read redefine stress as disruptions in homeostasis, because now it has a function, and it becomes in an energy conservation model. The disruption of homeostasis is shifting energy from serving the organs to serving the organism, survival. It's a Star Trek with the defense shields coming up. I got to fight off the enemy. I can't take care of the internal organs. And that's what disruption of homeostasis is. It's shifting priorities of the nervous system for the short term. That's why, as a resilient nervous system can turn to homeostasis or disrupt it for short periods of time, and recovery is just fine. We call that play. We exercise, then we recover. But if the system is already challenged, you don't have it in your repertoire the ability to play.
Mm-hmm. So can I ask, in terms of, just for my curiosity, so with the vagal efficiency, so when you're looking at your output, and I'm sure you can explain what you build in terms of the algorithms to help measure, is it you're looking at time in terms of how long it takes for the reading to go back to baseline? Or, I mean, can you talk a little bit about
The metaphor is really quite simple. If you were to measure over short periods of time the amplitude of respiratory sinus arrhythmia, which was observed in the early 1900s as an index of the inhibitory, cardio-inhibitory action of the vagus. So it was known in 1910 that this was a vagal indicator, but the quantification of it as an index of the vagal activity was really, that was still undeveloped when I landed into that area. And so we developed methodologies that are really state of the art in extracting that amplitude of that vagal component of heart rate variability, because heart rate variability has other things in it. It has slower oscillations due to vascular activity, due to baroreceptors, and most likely even due to the dorsal vagus. But the respiratory one is solely ventral vagus. It's unique. So the question is, what does the algorithm do? It really asks this question: how much bang for the buck do you get for this amount of vagal tone for you? So it's looking at a regression line, the slope of that regression line of sampled measures of respiratory sinus arrhythmia and heart rate over time. And to challenge the system, the protocols we developed have really been simple posture shifts: supine, sit, and then stand. No cognitive load, just simple underlying neurophysiological challenges. And that is really telling a lot. It's creating a model. We also did another study with people on a sedentary bike. And so they're seated on the bike, then they bike. And then when they stop biking, we watch the recovery. And in a person who has a efficient vagal efficiency index, or strong, they get a lot of bang for the buck. So if you pull back the vagus, they get a lot of heart rate out of it. And when the vagus comes back on, the heart rate slows down. So when you look at their curves, even the exercise people tasks, you see this covariation between the amplitude of RSA and heart rate. And in people with poor vagal efficiency, you see a disconnect. And part of that is sympathetics are coming on board. The other part is the feedback loops are just weak. And I think the weakening of those homeostatic feedback loops serve a function as if people are in chronic abuse or survive serious traumas. I think being numb has an adaptive feature. They're not feeling their body's pain. And I think this is part of that adaptive response. But it also leads to all those comorbidities that we're all familiar with: gut problems, cardiovascular problems that co-occur with trauma histories.
Mm-hmm. Yeah, so true. So I just want to backtrack just a little bit, just to make just a little bit more sort of explicit the connection from vagal input on the heart, because I know sometimes this part gets sort of confusing for some people, that we know that there is an intrinsic rhythm in the heart through your SA node, which maintains a constant beat, and vagal influences on the SA node will slow heart rate down. but we're talking about this underlying rhythm that comes through ventral vagal input on that SA node that
Yeah.
has a rhythm, an internal rhythm of its own, from the brainstem. So I wonder if you could just make that connection a little clearer, because I know it's what we're measuring in RSA, but just at that brainstem level, just sort of make that.
Yeah, so we'll go back to the intrinsic rate of the heart. So most people's intrinsic rate is really between 90 and 110 beats per minute. But few people have a resting heart rate of that level because the vagus is acting like an active brake on the heart. But it doesn't keep it down, locked down. It actually has an oscillatory feature to it, and it's called respiratory sinus arrhythmia. And so the most potent attribute or aspect of vagal inhibition on the heart is during exhalation. And if you think about calming mechanisms like yoga or meditation, it's all been about slow exhalations, abdominal breathing. And the afferents from abdominal breathing are actually amplifiers of that vagal efferent action on the heart. So much of what we already intuitively know, we know that if we calm the body down, our heart rates go slower. And we know that if we breathe slowly, meaning really that we exhale slowly, then our bodies calm down. And that is putting the vagal brake on. And a lot of people don't think about the mechanisms, they think about the behaviors.
So with that sort of vagal influence, and we know that there's a connection to respiratory, to our respirations, how with, because I know in the field of heart rate variability biofeedback, we have discussions around RSA, but then we also have discussions around respiratory heart rate interactions where people actually actively use breath work to help tap into that rhythm of when you breathe in, your heart rate increases slightly, and then when you breathe out, your heart rate slows down. So I wonder if you could sort of discuss that sort of connection to.
Well, with a lot of heart rate biofeedback, they push the breathing to even a slow frequency where they're breathing now 6 times a minute and not 10 times a minute. And that actually recruits other rhythms in the body, including vascular feedback loops, and that amplifies the impact of that slower respiratory action on the sinoatrial node. And so this has to do with what they call resonance breathing, coherence breathing, or Eastern breath, whether it's from India or Japan or China. It's all very much the same, slow exhalations. But there are other things that link into this. That is like chanting and singing, because those are slower exhalations. And even if we extend the duration of our phrases before we take a breath, those are vagally soothing. They'll calm us down. And if you see anyone who's anxious, they will often take a breath after a word or two. And they are conveying their anxiety in the staccato aspects of their vocalizations. But biofeedback, heart rate variability, or RSA biofeedback, is monopolizing on the actual neurophysiology of that vagal action. And the history of biofeedback is an interesting history as well, because it started off with a belief that you could control physiological visceral organs, heart rate, blood pressure, through conscious awareness, without motor intervention or motor interaction. So the earlier work was done under curarized, paralyzed organisms, because that had to do with the theory underneath it, not the practicality. And when the theory kind of fell apart, meaning that the replications in the paralyzed organisms weren't made, then biofeedback became a practical intervention that had effect, and the concern about the underlying theoretical link became less relevant. So the idea was, if you learn to breathe a certain way, if you do this, your heart rate slows up, blood pressure goes down. This is good. So we don't argue that point at all. And in the beginning, it was, what are the mechanisms that you're using? And I think now within the biofeedback community, there's, I would say, a more, it's coming closer to what would have been talked about as Eastern viewpoints of meditation and breath. I think there's a commonality between the practice of biofeedback and also some of the forms of meditation and breathing, yoga breathing.
Mm-hmm. 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 And so with that in mind, if people utilize those practices where you tap in and you practice, so for somebody who has an underlying not a strong RSA in terms of how they can maintain homeostatic functions in their body, so people who use those elements, which are considered like portals, in to help improve vagal tone. I mean, do you over time see underlying RSA improve, like the baseline reading?
That's an extremely good question. The issue is, what's the plasticity in a system? You can show that short-term manipulations, different types, and I actually did a study in the 80s using Rolfing methods.
Wow.
And we did two studies. One was just pelvic tilting the pelvis up, increased the vagal regulation on the heart. But you put the pelvis back down, it then goes back to where it was. Then we did a study where deep abdominal massage was being offered. That raised it immediately after, and stayed up for a while. I don't know how many days later we checked it, but it was still up there. So the point is, there is this concept of retuning. And so if we kind of like slip into the SSP world for a moment, the underlying theory behind that is you can retune your autonomic nervous system through giving cues to the brainstem. And the issues are that retuning, as opposed to increasing tone. A lot of people get locked into this metaphor of you make things stronger by challenging it. Polyvagal theory says, really, there are different states we can be in. And in different states, our nervous system is going to try to optimize certain survival strategies. If we're safe and calm, we don't have to use our defenses, and now our body can support homeostasis. We can be social, we can trust people, and we can be, in a sense, metabolically very efficient. But if we're under challenges, our body shifts state. And RSA, or heart rate variability, under the challenge states goes down, because they're reflecting heart rate variability, and in its refined form of looking at respiratory signs of arrhythmia. I'm saying refined form only because it's providing a neural window, understanding of the neural phenomenon. Heart rate variability is this undifferentiated variance of the heartbeat. In general, it reflects good stuff, but doesn't mean that. If you have arrhythmias, you'll have high heart rate variability, and that's not necessarily, well, it's not good. So we have to qualify. We have to know what we're looking for, what we want to optimize. And what we're saying is, if we optimize the impact of the respiratory rhythm on heart rate, this is good, because this is supporting homeostasis. Now, the question is, how do we optimize it? And, so this is this whole area of RSA biofeedback. And a lot of it, of course, is always going to be around the context of safety. And of course, the other major component is slowing the breathing up. And the slowing of the breathing is an interesting strategy that is historically built into traditions for hundreds of years. And that is slower meditative breaths that may, in a sense, recruit multiple sources for short periods of time. So when you breathe slowly, let's say 6 or even slower, 6 times or slower per minute, doesn't mean you're going to breathe that way after you go through your practice, but your heart rate could get retuned from that. The vagal brake can be retuned. So the experience of allowing our nervous system to express itself in safety enables a great expansiveness of the resilience of the autonomic nervous system.
Probably said. So I was hoping now just to maybe clear up some definitions, because I know when people are starting their learning journey in this arena and they're doing some of the reading of your literature, or they listen to you give presentations, there's quite a few new terms that people will come across. And I know you've mentioned vagal brake a few times today already. So I'm just wondering if you could just clearly describe that. I know you've alluded to it a little bit, but let's just.
Well, it's actually a word, a construct that I first introduced is 1996. And I was actually studying children. And contrary to the belief that if you had lower vagal tone was bad, what we were finding is that if children reduced their vagal tone during an intention task, they were the most social kids. So if they were doing this, and then we tested them, let's say months later, they were the more children who were more socialized. And what that was really talking about was their ability to regulate their physiological state. And so the vagal brake is really how we can modulate the inhibition of our heart in both directions, meaning that we can either slow our heart rate up, calm down, or we can reduce or pull back the vagal activity. So the vagal brake is, in general, we're talking about removing it to move. So we're getting energy by pulling it back. The notion of the vagal efficiency metric is really asking, okay, we have this vagal brake. How effective is it? How powerful is it? And also how effective is it? So, you could say, well, I have high amplitude respiratory sinus arrhythmia. I'm king of the mountain. Well, maybe not so true. Maybe it doesn't, maybe it just looks like you have all this neural influence, but your nervous system can't use it to regulate your body. And that's what the vagal efficiency says. It says what the optimal situation is to have good vagal influence on that sinoatrial node, and also to have the flexibility of pulling it off and putting it back on to support your body's needs. And the simplest task we used was posture shifts, which have no cognitive, no intentionality. It just triggers, because if you move from a supine to a seated to a standing, heart rate will get progressively higher, because there are blood pressure receptors in your neck that are saying, be careful. You're losing blood, is falling out of your head, literally. You have to keep the oxygenated blood up to your head. So the body has to adjust and uses heart rate to push the blood up, because that will give you higher blood pressure. We want blood, again, misunderstandings, like since we were afraid of blood pressure, we really should be afraid of low blood pressure, because that's where lethargy, depression, a true sense of depression, basically a feeling that impending doom. We like a degree of blood pressure because it helps us feel exuberant and enthusiastic and energetic. We like a lot of our sympathetic nervous system. It's not our enemy, but it needs to be choreographed or constrained by our ventral vagal circuit.
And I think when you use the word flexibility, I think was what resonates a lot with practitioners, is that often that we see people with trauma or individuals on the spectrum, and it's that lack of flexibility in that underlying physiology. And if you want to look at vagal brake, the flexibility of the vagal brake to withdraw or re-engage, and how efficient that is, which enables the overflow into increased behavioral repertoire.
Yeah, well, a quick notice of the populations you're talking about, the quick take home is that their bodies are usually in states of threat. So they're in defensive states. And it's not a choice. Then we often want to say, what are you scared about? You should be relaxed. If words would heal, there'd be no depression. Trauma would be just a discussion, and you say, oh, now I understand, everything's fine. But the body incorporates, gets retuned, and the words, those narratives, actually get distorted by the body state. So the narrative is always trying to justify the physiological state you're in. If you're in this very ventral, vagal, comfortable, safe state, you have tremendous flexibility in your personal narrative. But if you're dealing with clients that have severe trauma histories, they don't have that flexibility. They're at the edge of threat. And so the issue is, how do you convince, as a consumer, as the owner of the nervous system, how do you convince the nervous system that it's safe to be resilient, that it's safe to take chances? And the only way that I see it is actually going back to our evolutionary roots, in which cues of safety are really cues of co-regulation from others, intonation of voice, gesture, safe places. And that's actually where SSP came from. I viewed it as a stealth intervention that didn't require any type of explanation. The body knew what it meant. It meant that it was cues of safety. And cues of safety calm our autonomic nervous system. And of course, the counterindications with people with severe trauma is going into a calm autonomic nervous system is a great risk to them, because they're giving up their defenses. And so this was really the insights that many practitioners learned, was how to titrate and how to allow people to move into that. But to me, it was really this very interesting journey, I would say, to observe interesting journeys, that when you have someone with a trauma history, the naive view, and I would say I was the naive one, not the person who survived. I was a naive one. I said, couldn't we just give them distilled cues of safety, like a mother's lullaby? And if we think about SSP, it's an amplification of the intonation, prosodic intonation of cues of safety. I view it as distilled essence of safety. So wouldn't it be wonderful to give a person who is like this distilled cues of safety? Forgot one thing. A very important thing is that safety, defense was their protector. And their body now, when they would listen to this, would go like this for a moment. And then that accessibility through their higher brain structures was now interpreted as vulnerability. And then you get this destabilization, because they're getting the hell out of there, because they're now vulnerable. When a person without that history is saying, oh, wow, I feel really, really relaxed. And you're getting these two diametrically different reactions, but they're based upon the history of how that nervous system experienced the world. In one, accessibility is good. In the other one, accessibility equals danger. And this becomes how really trauma-informed SSP providers are working with people. It's really an interesting journey, as they basically empower the client to say, I'm destabilizing the client's now learning about how cues affect their body, and talking about, in a sense, understanding it and knowing when to stop. So you basically experience it until your nervous system understands that those cues are really not dangerous. And I use terms like faulty neuroception, which is another buzzword. It's like saying my nervous system is tuned to be defensive, and now I'll get cues of safety, but I'll have a faulty neuroceptive response. And I can understand why, because cues of safety make me accessible, but maybe I'm not ready to be accessible.
So I think this just segues beautifully into, how what are your ideas for practitioners for connecting knowledge base around RSA? And I know we have some tools and that we'll get to, but what are your ideas of how we can blend both together?
Well, it's a different, I would say qualitatively, it's a different biofeedback model, isn't it?
Yes.
It's like the journey, I see the journey of being a human as learning about our body.
Mhm.
So in a sense, if you're any type of therapist or provider in the mental health space, it's a psychoeducational space. It's not, and I think medicine has made major mistakes in the treatment of patients by not utilizing the power of psychoeducation, which means familiarity, expectancy, safety. Medicine has leveraged uncertainty and guilt, meaning that you better take your medicine or do your exercises. But what we learn is that expectancy is powerful in the nervous system because a violation of expectancy is threat. So we have to leverage everything about predictability. Predictability is not boredom. It's meaning that I'm not going to get hurt. And one of the things that you see with children who are on spectrum when they do SSP is that they start gravitating to novelty in food, novelty in social settings. They are directing it because the nervous system is now safe enough to incorporate new information.
So we know we can use some different tools like the Ion 2 or heart math or thought technology. There's quite a few other tools that we can use to help use sensors to measure RSA. And I guess I was just sort of curious about, I know you're involved with the Ion 2. If you can speak to that, and then we can sort of talk about how we can sort of couple that with helping clinicians help build that bridge to help practitioners or their clients develop that sort of interoceptive awareness, and how we can use.
What I think will happen is that, again, this goes into the psychoeducational portal where you're teaching your clients about their body's responses. So they are seeing that the body makes decisions that they may not be aware of. Physiological responses. So, okay, so let's go to the SSP Ion 2 connection. The SSP basically, when it's doing its job, meaning when it's not triggering safety in those who are interpreting, their body's interpreting safety as vulnerability, the body becomes calmer and the autonomic nervous system becomes more vagally organized, meaning RSA will increase. And hypersensitivities are decreased. Auditory processing improves. Hyposensitivity, human voice, decreases because now we pull in human voice better. And hypersensitivity, especially to lower frequency sounds, decreases. So we can see the nervous system shifting from being tuned to being in a state of defense to being tuned now to being socially or co-regulated with others. And the parallel of that system is the ventral vagus, because the ventral vagus is the brainstem area, and I call that area, it's not just my term, but it is a term, called the ventral vagal complex, because the area of the brainstem that regulates the vagal brake, that vagal efferent action of the heart, also regulates vagal fibers that regulate larynx and pharynx, meaning our intonation of our voices. So you would hear it in the voice of people being more intonation. But the other part is that area of the brainstem is affected and affects the other cranial nerves that include muscles, the nerves that regulate muscles of the face and muscles of the middle ear. So we start seeing faces that look more alive, more exuberant, and better neural regulation of the middle ear muscles, which enable the individual to deal with loud sounds and background noises, and which is coming through the facial nerve and part of it through the trigeminal. But what's interesting is if you had Bell's palsy, which is paralysis of the facial nerve, one of the symptoms, and it's only hemiparalysis, but one of the symptoms is hyperacusis. So you can see real life experiments of the impact of that facial nerve dysfunction affecting hypersensitivities. And one of the things that SSP is most reliably effective in is actually reducing auditory hypersensitivities. And so it's both calming and changing that whole ventral vagal complex to support more homeostatic, more safe, more spontaneously engaging. It was conceptualized as a neural exercise. Biofeedback is a neural exercise as well. Listening is less, I would say the intentionality is easier to just listen than to do a biofeedback, but it's not saying biofeedback is hard or wrong to do. I think when the IOM2 is remarketed to SSP providers, I think will give providers a relatively inexpensive objective measurement of that physiological substrate that they have inferred and was changing. We're putting the vagal efficiency metric onto the dashboard as well. And the whole goal of the re-engineering of it was to create a tool that was very relatively inexpensive that people could use for research, and the data would be publishable, of publishable quality. So these were the criteria I was putting on this device as I was working with them to re-engineer it. And we hope to have interesting package out there soon.
I know in some of the clients who I've supported with through the SSP, some more of my adults with other chronic fatigue, autoimmune conditions, I've supported using the IOM2 and using their resonance score. So doing baseline to sort of see what is their baseline, and then having them do IOM2 task or journey after, or getting another baseline after they've done the SSP. And it's been a nice tool to help supplement, but also provide that window when I see a resonance score start to drop compared to where it was, then we can have a discussion about what are they noticing. So I found it a nice tool to help supplement, but wonder if you could just speak a little bit about what that resonance score is at current and what the vision is for that to change.
Well, the resonance score is really based on having the person breathe at the frequency they say they're breathing. And it's actually derived from the heart rate pattern. So the breathing pattern is extracted from the heart rate pattern, because the frequency of respiratory sinus arrhythmia is respiration rate. So if you push that down, you are pushing that oscillation. And I was actually working with them on algorithms to make it a more reliable one. So it's pushing, first of all, let me say that what you're doing is the right thing. And so putting the two different types of tasks together. And the part that I think is important to, it's implicit in what you were saying, but I'll make it explicit, is to have the person talk about their experience. And with SSP and with the IM, with the journey, how are they feeling? What's their body doing? What's the awareness of it? Share your experience. Likewise, with SSP, what are the thoughts or memories or feelings that become awakened? I've had individuals say to me, the first couple of days I'm like this, but on day 3 I find it a little bit rough, and so it's kind of interesting where people are based upon their own history. And of course, as the more you become familiar with these tools like SSP, it becomes very predictable that a certain disruption earlier in life or an illness will be manifested as a person's body tries to, in a sense, experience. Is it safe enough to come out?
Very cool. I know this is totally backtracking, and it just kind of popped into my mind. So getting back to a little bit what we're talking before about RSA and that adaptability or efficiency in the vagal brake system. So what would you, just to help practitioners sort of add another layer, or if they start to add this technology to their work, what would they be expecting to see in somebody who maybe has an underlying background in trauma, anxiety, or depression?
Yeah. Well, let's say trauma or some. We're doing work with Ehlers-Danlos syndrome, which is a hypermobility syndrome, and we found some really did this research with the gastroenterologist, and now we're using the SSP as an intervention to reduce gastric pain. We're going to see how that goes. But the interesting part autonomically was that their vagal efficiency was low enough to discriminate at a high degree of accuracy that group of individuals with Ehlers-Danlos from other age-matched adolescents with gut pain. So the Ehlers-Danlos had low vagal efficiency. The other kids who didn't have Ehlers-Danlos but had gut pains had normal vagal efficiency, but they had lower vagal tone than age-matched controls. So you had this hierarchy. Normals, kids who without Ehlers-Danlos with gut pains, and then Ehlers-Danlos, their RSA was the lowest, but they had the lowest. They had atypical vagal efficiency. And what that taught me was that I think that the vagal efficiency is a surrogate for dysautonomia, another word that you have heard thrown around, which is really saying dysfunction of the autonomic nervous system. But let's go back to how we started the interview. It's a measure of disruption of homeostasis. That's dysautonomia. And I think this is a simple, efficient measurement of it. We've also done research with preterm babies showing it developing and how it changes with maturation and how it changes between sleep states. So we're actually trying to show that there's a certain trajectory that you anticipate that's associated with being healthier. And the other study that will be coming out shortly is that we looked at college students who have maltreatment histories, not PTSD, but maltreatment histories, not threshold level of PTSD. And they had significantly lower vagal efficiency. So it's like saying this is the antecedent for the comorbidities of all the gut problems and cardiovascular problems of this large, it's a significant part of our population that carries all these trauma histories, and they, in a sense, do okay for a while, and then you start getting it manifested in all the organs. And I think this is really the snapshot that will be the lead indicator. And so going back to where we want to go with this is that when we have these measures easily available to providers, they will be able to have a different dialogue with their clients. And if you can look at these measures over time, including the subjective tests, which are going to be on the dashboard, the assessments, the sensory scales, the body perception questionnaires, you as a therapist, as a provider, can have this very, I would say it's a sharing moment of where you're learning about the body. It's not being evaluated. We're not saying something's broken. And the journey will start showing that things are, in a sense, moving towards a more normalization or more normal. And that I think this becomes a wonderful story to be shared with clients, because they come into your space wanting to be fixed, but not knowing what's wrong. And I think this has been the inappropriate history of treatment models. That is that we want to fix people, both by the practitioner and also the person seeing the practitioner. I think if we shifted the metaphor to say, I'm coming to see you, Joanne, because I want to learn more about who I am. And you're going to help me understand what I am, and then I will learn to navigate in this complex world, as opposed to being told it's not really important how I feel.
I like how you said that. And thank you for talking about Ehlers-Danlos, because we actually did. I put out on our group to let people know that I was having a conversation with you, and if some people wanted to put in forward some questions, and we actually did have one regarding that diagnosis. So, and I think this heads beautifully into addressing maybe some of these questions that were sent in. I think this first one is interesting because of the impact of the state of the world right now. But could Dr. Porges weigh in on HRV and long COVID? I'm 1 year into long COVID and now have post-COVID dysautonomia.
Yeah.
Postural,
I'm part of a Wednesday night think tank group that's been going on for about almost a year now. That's one of the common, it's actually the group is quite polyvagal informed. And the issue is long COVID is the body's been retuned to be in a state of threat. And the other part, so we did a COVID study looking at my body perception questionnaire and childhood trauma questionnaires and looked at mental health symptoms during the pandemic, not disease vulnerability or disease recovery. And what's interesting is that, of course, you're going to say trauma history or adversity history results in more adverse mental health issues. But that's true, but virtually all the variants, all the predictive variants of childhood or previous adversity history, most of the variants, virtually all of it, is accounted for by a retuned autonomic nervous system.
I hope everyone enjoyed this episode. You may have picked up that I have a particular interest in the clinical applications of heart rate variability. I have provided short introductions to heart rate variability in some of the workshops that I have run. I think that it is a very important area for therapists to know about. As such, I'm offering 2 short courses. The first is Polyvagal-based heart rate variability, an introductory course. And the second is SSP and heart rate variability biofeedback. I'll have information noted in the podcast show notes about how to register and a brief summary of each course. And I'll also post this information on the Safe and Sound Protocol podcast Facebook group. As always, please leave any feedback, any thoughts, any suggestions in the Facebook group discussion. And otherwise, everyone take care, breathe and smile. Joanne.
If you'd like to learn more about the Safe and Sound Protocol in Australia and New Zealand, please contact Integrated Listening Australia. The website is integratedlistening.com.au, and for the rest of the world, please contact Unite Integrated Listening at integratedlistening.com.